Bueno, vamos a continuar. Revisión de algunos temas ahí presentados en los congresos europeos. Este fue al final del 2019 un panel de discusión sobre cómo aproximarse o cómo tratar, cómo iniciar las combinaciones de medicamentos para hipertensión arterial pulmonar. Entonces vamos a comenzar.
Discussion, general discussion. Can we have some more light, please? There are microphones for questions from the audience. No questions?
If I may start with Pascal. Oh, there is somebody? So come to the microphone, sorry. We cannot see.
Good afternoon, everyone. This was a very educational lecture, thank you. My first query is that whenever I see patients in OPD of severe PAH, usually in India the patients come late to us and present late to us, like Marie. Supposing the blood pressure at the starting point of initiation of a dual treatment is approximately 90/60 and systolic 90, and we start dual therapy with a PDE5 and ERA. And then suddenly, when after 2 weeks of follow-up, 3 weeks of follow-up, the patient comes to you with a BP of 70 systolic. Then how do you approach the patient then? Do we stop the treatment? And then what, any other thing which can be done?
So the question is hypotension after starting double initial combination. Actually, no, if you want to answer, or
they are relatively well tolerated, the double oral combination therapy, and it's quite rare to have to stop the medication because of hypertension. So I think that you have to look at the other drugs, in particular diuretics, in order to stop or to decrease the dose of diuretics in order to do not have this hypertension. I'm not sure that the hypertension was directly related to the combination, the PAH combination therapy.
Yeah, I agree. And the way you combine the drugs in an initial combination strategy is not to give the highest target dose the same day in the same hour. There is a sort of up titration which allow in a maximum of 4 weeks to have the highest tolerated dose. With this strategy, hypotension is very rare, and we acknowledge that the majority of the patients with PAH may appear to be mildly hypotensive. Sometimes they have 105, 110 of pressure. This is due to low cardiac output. But the effect of drugs overcome this problem. So hypotension is not a problem. Also, hypotension is invoked when diuretics are given to these patients because they have heart failure. But also in this case, we never see hypotension even after treatment with diuretics. So probably many of these patients can get concurrently double initial combination therapy plus a dose of diuretic. Also in this case is very rare hypotension.
Thank you.
Yes, microphone number 2. Please identify yourself.
Angelo Valencia from Colombia. I have a question. Mari had in the baseline evaluation a variety of criteria of risk evaluation, high, intermediate, and low risk. What risk criteria has the more weight? because she had a cardiac index low, very low, and other intermediate and low risk. What have the high weight?
Valerie?
So I think you're making some very good points. When I looked at this case, when I looked at Marie's risk assessment, I look at her, especially in a 52-year-old woman. She had enough high-risk factors for me to have given her the discussion about a parenteral prostacyclin. And I think Mark and I, in the old days, even as recently as 5 years ago, would have had initial IV therapy on her list. So I would have discussed that with her. And I think that could have been an option for her. I think the other option with very close follow-up is that upfront double combination therapy. So I acknowledge your point, and I think that could have been an option in many practices, especially if she had good family support and, and that sort of thing.
Maybe another thing, thank you very much, Val, and thanks for the question. We worked a lot, of course, on risk stratification and risk stratification instruments. All the risk stratification tools derive from retrospective analysis, and the validation are on retrospective registries. Right now, we have prospective registries in order to give the exact weight for each parameter. But the French approach, which has been discussed a lot by Pascal and Valérie, really focuses on 4 parameters invasive, 2 and 2, or 3 non-invasive. And I think in the retrospective analysis, it performs quite well, and it has been cross-validated in Compira. So it's a good start. It doesn't give a weight, but it gives a selection of meaningful parameters, and more work to come.
A question from Dr. Guillermo Bortman from Buenos Aires.
Thank you. Thank you for the talks. I want to ask you, when Marie started, she had 36 centimeters in the right area, and 13 months after is 20. How often you see such a change?
In fact, I think there has been underestimation. There is a reduction, but this testifies the limitation of echo in the measurement of area. So I think we cannot consider precise numbers, but the trend to a small reduction.
And I think in her, she was in pretty significant heart failure when she was first diagnosed, and so I think that change was the combination of diuretics and therapy, pH therapy.
Yes?
Thank you. Ivan Stankovic from Serbia, Belgrade. How would you approach this patient if she had portal hypertension and liver impairment, for example?
Hypotension again?
How would you approach the same patient, Marie, if she had portal hypertension and significant liver impairment? Would the sequence of drug would be the same or not?
Usually in patients with portopulmonary hypertension, you see a high cardiac output, even in patients with important pulmonary hypertension. It is unusual to have a low cardiac output at the beginning in patients with portopulmonary hypertension. But if this is the case, because we cannot exclude anything, I believe that initial oral combination is appropriate also in this case.
And this patient often have a very good response to the double combination therapy.
Indeed.
Yeah. No other questions? Maybe we can rediscuss again the way we assess the risk, because as you can see, the table of the guidelines provides some straight borders between low, intermediate, and high. And this is not the real world. In the real world, we have border patients, patients who may be considered at low or at intermediate or even high according to different point of view. So maybe the panel can answer what they do in this case of patients, how they interpret border patients which overlapping scores. Mark?
Yeah, that's everyday's business indeed. The first thing I would like to say is that we are very lucky to have lots of drugs approved for these patients, and I'm very ambitious for the patients, and maintaining or attaining the low risk is my priority. Of course, I use a lot the French approach, and I give a different weight to the question to the 4 from the French as compared to the others. If a patient is borderline and with different parameters in different zones, I usually take the decision to treat hard. And if the patient is intermediate high, as Marie, I still consider triple with the parenteral prostacyclin. She did very well on double and sequential triple, but I think we can still consider triple in those patients. Then, when it's borderline low and intermediate, clearly the beauty of the recent World Symposium proceeding is that you merge them together and you prioritize quite tough treatment, quite good treatment, oral double combination therapy. So because we have room for improvement and efficacious drug, I usually consider the patient as worse than they might be, and I take the decision to treat hard.
Mark, can I ask you a question about how you approach one of the parameters that's in the guidelines and the French, and that's the hall walk. And this kind of magic number of 440 is from retrospective analyses, as you say, but in everyday life, when I look at a hall walk on one of my patients, coming automatically on the report is the predicted hall walk for age, gender, and height. So, for example, Marie here, who's only 52 years old, that hall walk of 423, I guess it puts her at the high end of the intermediate, but I expect much more than that from a previously fit 52-year-old. So can you tell me how you approach that in everyday life?
Yeah, no, I fully agree with you that we need to be sometimes more ambitious than the guideline supporting cutoff. For Marie, I don't know her height, I don't know her body weight, so I need a little bit more meat to say if 450 meters is right or wrong. But I agree with you that in young patients, and 52 is young, we are sometimes quite ambitious, and we have a lot of BMPR2 mutants in my center because we have the French National Referral Center, and many young patients come, and we want them to walk 600 meters because they are young and fit. But as you said, and everybody say that, it's not fixed, it's not the Bible, okay? It's à la carte. Same for 82-year-old scleroderma patient. They will never reach 440 meters, but they may do well, however. So I agree with your comment, and we have some flexibility.
In Bologna, we have simplified a little bit the number of parameters, reducing to 4, so functional class, 16 walking distance. We have grouped together right atrial pressure and BNP plasma levels because they are very, very correlated, and cardiac output and mixed venous oxygen saturation because also they are very, very correlated. So at this point, our definition of low risk is to have 3 of these parameters. So it is possible also completely non-invasive. And high risk, which is very important, 2 parameters of high risk, but including cardiac index. So all the rest is yellow. Of course, this is just for practical reasons, and we have validated internally. It looks like it works. So we avoid some overlap patients. But I have another question. After the first treatment, and this happened also to Marie, more than 50% of the patients remain in the yellow zone, intermediate, despite even initial combination therapy. So don't you think that maybe we need to divide the intermediate group in intermediate high and intermediate low in order to decide which type of prostacyclin agent may be used? Because now we have invasive and non-invasive prostacyclin agents.
I think that's a really good point. And one question I was going to bring up to the panel is how do you work echo in? How do you work RV function in? I think one of my theories is that echo doesn't fall onto any of those tables because it's just hard to quantitate. It's not often quantitated and published in all these retrospective registries. But when I evaluate that patient, like when I would have evaluated Marie at that time point, looking at her echo and looking at the size and function of her RV on the echo is something that might push me. If she had, moderate to severe or an ugly-looking right ventricle, I might be more aggressive with therapy at that time point.
In Lille, we really love cardiac index, and we still love the cardiac index. And in the case of Mary, even at 2.8 in a young active woman, we'll prefer to see a cardiac index greater than 3 to be sure that she will be fine for several years. So it's really important to follow up the patient after that, even if you have a lot of green parameter and very few yellow parameter, but the follow-up is really important, and to not hesitate to perform a risk assessment. So after that, I think that BNP is a very powerful prognostic parameter. As I said before, we have to have a normal BNP. And as Val said, we're cardiologists, and we're looking at the echo and the global right ventricle function, and not only a parameter with a cutoff value.
Yeah, I agree totally with you. I will be very short. The vast majority of patients are in the intermediate group, so Nader Renault's point is very important, and we need to work very much on improving the granularity of the intermediate group. So that's your key question, and a very good question.
Yeah, and this brings me to the closing remarks. As you can see, just analyzing a real case, a real clinical case, we have reached the cutting edge.
Perdón. Creo que de aquí podemos sacar como la estratificación del riesgo, ¿no? Cuando se ve a un paciente con hipertensión arterial pulmonar, que está descrito en las guías, pero como ellos, los expertos, abordan estos problemas, ¿no? Los pacientes que pueden quedar en el medio de los riesgos, ¿no? Entre bajo e intermedio, o intermedio y alto. Y lo interesante son las cosas que expresan ellos, ¿no? Por ejemplo, los 3 parámetros clínicos que te pueden poner un paciente en bajo riesgo, que es su clase funcional, el BNP y la caminata de 6 minutos o 600 metros, ¿no? Entonces, interesante eso. Creo que podemos ver algo de embolismo pulmonar. ¿Ahí están todos?
Sí, doctor.
Sí, doctor. acute pulmonary embolism del Congreso 2019. Y
I have no interest to declare. This is the task force of the 2019 guidelines on acute pulmonary embolism. And despite the lack of new randomized control studies in this area, many refinements have been proposed in different areas, including diagnosis, risk stratification, and treatment. And we start with the new definition of hemodynamic instability in pulmonary embolism, and this is identified by 3 possible clinical conditions, like cardiac arrest with need of cardiopulmonary resuscitation or obstructive shock, defined as hypotension despite adequate filling status and an organ perfusion. And also the old definition has been included: persistent hypotension, blood pressure less than 90 millimeters of mercury systolic, or drop more than 40 millimeters, lasting longer than 15 minutes. And if this is identified, and we are in the area of high-risk PE, a bedside transthoracic echocardiogram need to identify a right ventricular dysfunction, otherwise other cause for shock should be identified. In presence of right ventricular dysfunction, it's important to have a CT pulmonary angiography to identify the acute pulmonary embolism as cause of shock, but sometimes this is not possible for the conditions of the patient, so also a compression ultrasound in combination with right ventricular dysfunction may identify patients at high risk. In patients not at high risk, another diagnostic algorithm is proposed, similar to the previous one. Here we need a further stratification based on the likelihood based on the clinical probability of acute pulmonary embolisms. If the clinical probability is high, based on personal judgment or based on well-known tables, a CT pulmonary angiography is required to confirm acute pulmonary embolism. If this is not confirmed by CTPA, maybe further examination needs to be performed, including the pulmonary ventilation perfusion scan. For example, this is maybe required in patients with renal insufficiency. In case of intermediate or low clinical probability, the dimer test is required, and in a new version of the guidelines, the dimer threshold have been proposed according to age or clinical probability. If they are positive, then again CTPA is required for the diagnosis. And these are the recommendations about the dimer, about the compression ultrasound for the confirmation of proximal deep vein thrombosis and lung scintigraphy. Then after the identification of non-high risk acute pulmonary embolism, after the diagnosis, we need a risk stratification based on clinical parameters alone or combined in scores like the simplified PESI or HESTIA. And as you can see, in patients with high risk, we need hemodynamic instability and right ventricular dysfunction as assessed by transthoracic echo or CTPA. And also, in case of intermediate risk acute pulmonary embolism, it is required the clinical severity, but also right ventricular dysfunction or elevated cardiac troponin. If both are fulfilled, an intermediate designation is proposed, intermediate high designation. If only one or is present, intermediate low risk is defined. Otherwise, we have a low risk acute pulmonary embolism. A very important new definition new proposal is for non-high risk when oral anticoagulation is initiated. The highest recommendation is for new oral anticoagulant, not anymore for vitamin K antagonist. And then also the suggestion of multidisciplinary teams for the decision-making in complex cases and the use of ECMO in advanced case of high-risk pulmonary hypertension, acute pulmonary embolism is proposed. This is a comprehensive risk adjustment strategy. Then once the diagnosis is clarified, anticoagulation is proposed. Again, hemodynamic instability needs to be clarified. And if there is no hemodynamic instability, we need to the further stratification according to clinical sign or right ventricular dysfunction. If both are present, then we are at intermediate risk, otherwise at low risk. For high risk, we have a fast track to treatment and reperfusion treatment is proposed. In case of intermediate risk, further stratification is based on troponin negative. We have intermediate low and need only anticoagulation and hospitalization, while in intermediate high risk, we need monitoring in intensive care unit to identify possible deterioration and then need for reperfusion therapy. For low risk, in presence of no other reasons for hospitalization, family or social support and easy access to medical therapy, early discharge need to be considered. For high risk, initial anticoagulation is for unfractionated heparin because the highest recommendation is for thrombolytic therapy with also level of evidence B. Otherwise, in presence of contraindication to thrombolysis, absolute contraindication, pulmonary embolectomy, surgical pulmonary embolectomy is recommended. Otherwise, if this is not present in an hospital, if there is not a cardiac surgeons available, percutaneous catheter-directed treatment with a class of recommendation 2A and level of evidence C is proposed. In high risk, obviously, vasopressors may be required, and also ECMO is proposed, but in combination with surgical embolectomy and in combination with catheter-directed treatment. Recent paper showed that ECMO combined to thrombolysis did not show favorable results. And then there are also new recommendation for extended treatment, extended anticoagulation after the first 3 or 6 months. For example, indefinite treatment with vitamin K antagonist is proposed in patients with antiphospholipid antibody syndrome. And when there are also no identifiable risk factor, also in this case, extended anticoagulation should be considered, evaluating the risk of recurrence and the risk of bleeding. There are 2 tables proposing scores for risk of recurrence and risk of bleeding for extended anticoagulation in the guidelines, which may help the choice. Another new recommendation is for pulmonary embolism in presence of cancer. The treatment was based in the previous guidelines on low molecular weight heparin. In this case, also edoxaban and rivaroxaban may be considered as an alternative. And then the diagnostic workup is adjusted in presence of pregnancy. A low molecular weight heparin is the treatment of choice for anticoagulation. Chest X-rays and compression ultrasound is proposed at the beginning, and in presence of proximal deep vein thrombosis, treatment can be continued. If DVT is not present, CT pulmonary angiography or perfusion lung scan can be considered in presence of a normal chest X-ray. is important, very important, to rule out the presence of acute pulmonary embolism, but if acute pulmonary embolism is confirmed, the anticoagulation with low molecular weight heparin is suggested, but also assessment of severity need to be considered, because it may be required thrombolysis, even if thrombolysis pregnancy is considered partial contraindication of thrombolysis, but in case of high risk, this may be proposed, including also other possibilities like embolectomy and catheter embolysis. Then after the 3 to 6 months period of anticoagulation, new recommendations are proposed for symptomatic patients, patients who are symptomatic, become symptomatic, or remain symptomatic with dyspnea, and there is an algorithm to guide the possible management strategies. In case of dyspnea, then transthoracic echo needs to be performed, and the evaluation of the probability of pulmonary hypertension is required, low, intermediate, or high, and also risk factor for chronic thromboembolic pulmonary hypertension need to be considered. And in presence of high probability of pulmonary hypertension by echo, a ventilation perfusion scan need to be performed, and if it's possible, the patient need to be referred to a center expert for chronic thromboembolic pulmonary hypertension, while in patients with no risk factor for chronic thromboembolic pulmonary hypertension, the withdrawal of anticoagulation is required. So the entire spectrum of clinical possibilities and all different important phases of treatment, initial treatment, length of treatment, and then the follow-up strategy have been refined in a very clear way for these guidelines. Thank you. I have no interest to declare. This is the task force of the...
Ok, perdón. Bueno, muy bien. ¿Algún comentario? Ya las habíamos revisado, ¿no? De medicina, nada más así los remarks que hace el doctor Galí. ¿Algún comentario?
Sí, doctor. Pues yo creo que es muy interesante siempre el abordaje de la tromboembolia pulmonar, desde la primera presentación que hablaban de iniciar la doble terapia conjunta, si presentaba algún efecto adverso, que decía el doctor que había evidenciado poca hipotensión en este tipo de pacientes. Los pacientes que tienen un riesgo intermedio alto, riesgo intermedio bajo, que siempre es algo que genera un poco de duda en cuanto al abordaje, y lo basado en las guías, creo que llama mucho la atención el tener siempre en consideración. Las guías son muy puntuales en decir qué pacientes, de acuerdo a las características clínicas, tienen mayor probabilidad de desarrollar tromboembolia pulmonar, ya sea pacientes que tengan alguna cirugía mayor, pacientes con enfermedades autoinmunes, que recibieron tratamiento quimioterápico, y pacientes que tengan cáncer, eventos vasculares cerebrales. Son pacientes que los ubican dentro de un riesgo moderado, un riesgo severo, de poder desarrollar tromboembolia pulmonar. La importancia de las clasificaciones, tanto del PESI, el GESTIA, que son algunas de las que más toma en cuenta la guía para el dar criterios de severidad, y la importancia del ecocardiograma, ¿no? En los pacientes con inestabilidad hemodinámica, las características específicas que podemos ver que nos pueden hablar de algún de tromboembolia pulmonar, y el completar el abordaje diagnóstico con una angiotomografía. En el caso que no sea posible, pues si vemos algún hallazgo alterado en cuanto a la función del ventrículo derecho, pues tener en consideración y tratarlo como una tromboembolia pulmonar. Y obviamente siempre tener en contexto las características clínicas o la forma de presentación del paciente.
Sí, perfecto, sí, Miguel. Exactamente, sí, no, es el repaso, ¿no? de cómo abordar y donde la angiografía por tomografía es una parte esencial, ¿no? Y donde Dímelo también sigue jugando parte del abordaje diagnóstico. Perfecto. ¿Algo más, Ricardo, Poncho, Erika?
Nada más, doctor. Pues sí, realmente ya hemos tocado todos esos puntos, a lo mejor un poco más en extenso, pero siempre es importante escucharlo de la voz del experto, ¿no? Yo creo que nada más que agregar.
Perfecto. Ok. Erika, ¿alguna duda o pregunta?
No, doctor, todo bien. Creo que es muy clara la explicación que da el doctor. Pues siempre pues iniciar, ¿no? Desde el abordaje, dependiendo de la presentación que tenga el paciente, que si está inestable o estable, pues de ahí vamos a ver qué estudio podemos realizar de abordaje inicial con ese paciente que tiene la sospecha de tromboembolia pulmonar, pero pues realmente creo que es muy clara la presentación y los algoritmos que da el doctor.
Perfecto. Sí, entonces, el viernes revisamos estos últimos dos, que fueron los del Congreso de este año. Acerca de long-term outcome sostenible de la hipertensión, recibiendo la triple terapia oral combinada, como una de las cosas de la discusión del foro también era de que no hay que darles el golpazo así de un inicio, ¿no? El que preguntaba, que provenía de la India, que les causaban la hipotensión sistémica. Ir ajustando poco a poco pensamos que va a ser una doble terapia, ¿verdad? O entonces primero uno y después el otro, ¿no? No de golpe porque se ponen mal los pacientes. Este es del estudio Tritón. Y el otro es cómo elegir el tratamiento adecuado y cuándo empezarlo. Ok, lo revisamos el viernes. Ingresos no, ¿verdad? Ingresos no. Al servicio no. Ingresos no.
No, doctor, parece que no hubo ningún ingreso.
Perfecto. Ok, nos vemos en unos 20-25 minutos. Gracias.
Sí, doctor.